You're in.
All right. Hello, hello, and greetings to everyone who is joining us today. We are getting started. I have called a code. I have a rapid response going. I have hit the code button. There's a panic. I need you, any and everyone to join. If you are joining right now, please share this to your page. Please tell everyone to join in right now. Jeanna needs her code team ASAP. I only have about 15 minutes worth of compressions in me anymore. I used to be able to handle a code. I've compressed for 45 minutes straight, and it was not a good scene afterwards for me because doing compressions as a nurse, and when you're in full PPE, which, you know, right now, the nurses who are on the front lines, who are trying to save the lives of these COVID patients, who are doing compressions and running codes in full on PPE, it is not easy. And so right now I just have to take the crown and hand it to each and every one of them, all of those teams right now who are doing this. Thank you. I know it's not easy. I know you're hot. I know you're sweating, and I know that you're exhausted, but you know, you can't even, there's no words that describe it. But I'm using this, piggybacking on that drama of Code Blue, because we have CalCare back in the assembly, folks. And this is a very important, very exciting time right now, but we have no time. We actually have negative time. We are overdrafted on time. And so I want each and every person to kind of be here to hear what's going on so that we can get California guaranteed healthcare for all. If you have not been paying attention, and or you're just coming back into it, you took a break for the holidays, which I did, I totally understand and respect. Big proponent of a mental health break, which, by the way, did you know mental health is actually included in CalCare? And so that is a big thing, because as I was having my mental health moment, you know, I'm sitting here looking for therapists and everything else. The one therapist I like didn't accept my insurance, and it was like 200 something an hour. And yeah, people think that nurses make good money, but then there's taxes and then there's a cost of living. And so $200 an hour was not just something I could afford. And so, you know, even exploring through my insurance, trying to find a good therapist was not very easy. So, you know, the fact that mental health is included in CalCare is super duper amazing. And I think will be a tremendous help to all of us, especially after this time. So I just want to put that out there. I also want to say once again, just for those of you joining, I know a few more people have joined in. Welcome to CalCare Office Hours. This is sponsored and put on by Healthcare for All Los Angeles. Woot woot. We're a single payer organization. We're joined by PNHP, the doctors that care. They're joining with us. And I know somewhere in there, CNA, the California Nurses Association, loves us too. You know, they have officially said it, that they love us too. And we've worked so closely with them and love them. And so so I want to go right into this. Let's go back to the very beginning. Yeah, I haven't done an office hours in a minute. I've missed you guys. Obviously, is she caffeinated? Is she excited? It's just pure excitement. I've had no caffeine today. So I want to go into what is this CalCare thing that I'm ranting on right now? So I'm going to share my screen here and we're going to go over the basic principles. Paul, good on my screen? All right. So yeah, CalCare is a guaranteed healthcare for all. Emphasis on all. All means all. It is a cure for our broken healthcare system. It is a guaranteed healthcare as a human right in the state of California. And we're going to provide comprehensive, high quality healthcare to all, just like Medicare for all would do nationally if Congress would ever get their act together. But when we say all, I do mean universal coverage. We're talking about everybody in and nobody out. And we mean everybody. Your body is in California, you should be covered. As long as you're living here in the state of California, we love you. We want you to be healthy and living your best life. And that's regardless of your race, your sex, age, gender, your country of origin, your disability status, immigration status, marital status, income. And you're going to get the care that you need regardless of your ability to pay. And that this also kind of briefly touches on the medical apartheid. So, you know, if you're low income right now, you could say, okay, low income has Medi-Cal, they have CHIP. And, they have they are supported by programs that are for low income. That is medical apartheid, because the literal care that they get is so different than the care that someone who's insured with a PPO, well employee sponsored insurance plan gets. It's totally different. And it happens right here in the city of Los Angeles. The care that you get in South Los Angeles might be a little bit or a lot of it different than the care you might get in West Los Angeles. What's that about? Anyway, we're talking about a single public program, single payer, publicly funded through progressive taxation. Oh my God, she said the word taxes. We're going to talk about that one later. I'm not going to go into it right now. We're going to cover all necessary care here in California, eliminating billions with AB, and bloat and waste, and saving people thousands on their healthcare costs. Yes, we will save you thousands. And truthfully, whatever may increase or whatever tax may be applied will actually still probably put some money in the average person's pocket. Once again, we're going to talk about that later. I'm not going down this tangent right now. We're full comprehensive benefits. This includes medical, dental, hearing, vision, mental health, which I just went on a tangent about earlier, prescription drugs, long-term care, that is very important, and more. So if you right now are taking care of your parent or a loved one because you can't afford to have a caregiver, which is not covered by many insurances, if any insurances, nor is it covered by Medicare, this plan is for you. If you hit the Medicare donut hole and are paying hundreds of dollars for your medications, or if you can't afford to pay for your full months of prescription because of that Medicare donut hole, this plan is for you. If you are having mental health issues and you can't afford to go see a psychologist or therapist, or, this plan is for you. If you are having a toothache right now and you're hoping to God that it is not something serious, but it can be getting more serious every day, this plan is for you. If you have cataracts and you don't have vision insurance, this plan is for you. So this plan, once again, is for everybody. And all decisions about your care should be between you and your doctors and nurses, not the insurance companies. How many times have you or someone who had to go and get something approved from insurance? Their doctor told them they need a test, they need a medication, they need a procedure, and their insurance denied it. And they had to fight it and fight it and fight it, delaying their care, and finally getting it approved. How many can say that they've known someone that did? If you haven't experienced it directly, you may know someone. And if you don't know someone, then, well, that's good on you, because it's really a lot of people out here experiencing this every single day. So then you have freedom to choose your care provider. Under CalCare, there's going to be no more in-network, out-of-network. You're going to have the freedom to choose any hospital or doctor you like. Isn't that great? No more network, no more saying, oh, well, I can't go to this doctor because they're not in network, or, oh, I can't go to that hospital because it's not in network, or you end up at that hospital because you didn't know really what your network is, who really looks at their benefit packages. And you get this huge bill because the hospital, I hate to admit it, we're not the best at telling you, oh, by the way, you're out of network. We barely tell you if you're inpatient versus observation, and that is a huge difference in price. So to tell you whether you're in network and out of network, you may not find out until after you're home and you got that bill. Ooh. But under CalCare, that would never happen. You will never get a, $50,000, $60,000 bill because you were in an out of network hospital. That won't happen, but it can happen, and probably is happening. I for sure know is happening right now. So now we're going to talk about free at the point of service. No more co-pays, premiums, or deductibles. You arrive at your doctor's office, you arrive at the ER, the urgent care, and you show them your CalCare card, and that's it. Please have a seat and wait for the next available doctor or nurse to come see you or get triaged. Done. 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 Right now, what's going on is that we are, there are co-pays being collected at bedside. You will get a call to your hospital phone and say, hey, this is such and such from the financial counseling office. We want to let you know you have a $2,500 copay. You want to put that on cash or card? You're sick in the hospital. You've got a tube in your arm. You've got a tube in your nose. You may be on oxygen. You're right now, that's going on every single day. I get patients freaking out asking me, well, why is it that my insurance isn't covering this? Why do I have to pay right now? Well, that's your copay. Your copay is due at the point of service. But guess what? Under CalCare, it's not. That would not be a conversation I'm having with patients at the bedside, as they're very anxious, by the way. And I'm not making that up. That literally happened to me, except the 2,500 was actually 5,000. So that literally happened. And that's how I know the conversation so well. It's ridiculous. And it was why? Because they had a high deductible plan from the flipping marketplace, covered California. So your Affordable Care Act, I hate to say it, ain't so affordable. Okay, moving on. Just transition. A just transition means funding and programs to protect and support any displaced workers in the insurance industry. I'll be honest, I don't care about the CEOs, but I worked on that side. I know the faces. I know people who work for the insurance companies. They're not bad people. They're doing their job. They're doing it to the best of their ability. A lot of them ain't that happy, but hey, it's paying the bills. They're going to keep doing it. I know the faces. So when I know, as the people who will oppose this will say, what about the jobs? How we don't care about those people. I do care about those people. I can name those people. So I know very much so that what I'm doing here, yes, we'll shake up things. We'll create a little shaking up the snow globe a little bit. But at the same time, I will alleviate pressure off of them. Right now, they are miserable. They are working under so much pressure to get so many referrals processed, to get, under so much time. And then you do all of that and you hit these ridiculous metrics set forth by these corporations. And then you get a 1% raise, 1%. Now, I know we shouldn't complain, right? The corporations are like, oh, 1%, congratulations. Like literally you get that. Once again, I'm speaking from experience. I got before I left the company I worked for before, my last raise was 1%. And I managed an entire region through a pandemic and I got 1%, which was barely $1, by the way. So I know people, coordinators, the people who are processing these referrals, doing a lot of the front end work, would literally get paid more at Chick-fil-A. Literally. I saw the wages and I was just so because I knew that I was working them so hard, knowing that they would get paid more at Chick-fil-A or In-N-Out. In-N-Out pays really well. So, I know that from experience. The just transition is to provide a program or to provide opportunities for people who are working for your Anthems and your Blue Shields and things like that to come over. And maybe work under CalCare. We're going to need so many of those people. Just because, we're creating a single payer program doesn't mean we won't need, certain administrative things to happen, utilization things to happen. We're just putting it all under one house, like one house, one house. We're one big family under one house. Instead of having, I think, 100 and something houses right now, AKA insurances, that just for the state of California, it's ridiculous. So we're going to do that. And that's a very important part of this bill. And then lastly, patient care based on patient need. We're not going to have financial incentives to avoid providing patient care. Gina, what do you mean by that? They can't deny care. I'm like, you're absolutely right. They can't deny care. What they can do, though, is find the places that have the cheapest rates and put those in your top network, so that those are you have to utilize those places or pay a lot higher to go to the nicer places that have higher rates. That's what I'm saying is financial incentives. No, your doctors aren't getting paid off anymore. Yes, they have, nationally have put in regulations that avoid that. But when I say that the insurance companies they literally go around shopping for places and hospitals and clinics and things like that have cheaper rates, not really focused on their care outcomes, just focused on what is your rate. And then they put that network together so that you have to utilize the network they put together, that they shopped for, that they know provides the cheaper rates. That's the financial incentive to avoid providing necessary care. That's what happens. Real talk. And we're going to get rid of that. Once again, we're putting everything under one house. So you're going to get the care that you need. Not everyone needs a Brazilian butt lift. I'm not saying that that's happening. I had to bring back the Brazilian butt lift. I'm sorry. But not everyone, that's not necessarily patient need. Even though I know some people may say that they need it. But you should not be, let's say your cardiac procedure is a need, okay? If you've got a clogged artery that needs to be, I call it roto-rootering out or catheterized, then you should have that done quite, soon. And that should not be held back due to utilization processes as they try to find you the best place to have your procedure done, AKA have a cheaper rate. All right, so I've gone off on a little bit of a tangent, but that is your basic principles. This is what CalCare is. And I love it. I think that it's great. I think that's why so many people and so many of us have dedicated so much of our time to this. And those of you who are, kind of new to this right now, CalCare just got brought back into the assembly after taking a little bit of break. We kind of, our beloved assembly member, Ash Kalra, who is the author of this bill, along with Miguel Santiago and Alex Lee. I'll go through the rest of the names later. They, took the bill down to polish it a little bit, answer some of their questions from their colleagues who are asking all about the financing. And so now it is back in the assembly. It passed Rules Committee. Hey, yes. And now we're heading into the Health Committee on Tuesday. So I wanted to share just really quick another little slide show of mine, because that's what we're going to go through this before we get into a more open discussion. Share screen, and where's my PowerPoint's gone. Oh, Zoom. Did you guys know, while I'm sitting here struggling, that it is day 662 from the time we went into our first stay-at-home order on March 19, 2020. Yeah, fun fact, 662. I'm laughing, but I'm really crying. I'm like, wow, how did we even get here? Why are we even here? Oh my God, I was bragging to Paul about how I had all this kind of worked out. And I'm like, oh yeah, you just have to, I don't have that much to share and I can't even get this crap up. Ugh. I don't know what's going on. Oh, here we are. All right, screen is being shared. Here we are. So I just wanted to share. Sorry, I gotta make the faces small. I just wanted to share a thank you to our, like I said, esteemed assembly members who are fighting for this. Ash Kalra, Alex Lee, Miguel Santiago, our authors, our principal co-authors here. And then, our co-authors, and these were who were on the initial bill. This list has grown. For example, I know my assembly member now, Isaac Bryant, has signed on since the bill's back in. I know Wendy Carrillo's on board. There are several people who are on board now that aren't on this list. It was just, I was looking for the updated list and I couldn't get to it or find it in time, but there are so many more. So in the Assembly and the Senate, those of you who are signing on, those of you who have seen the energy, the momentum, the people you're hearing and listening to your constituents, I thank you. I was on a call, the LACDP Power to Heal screening yesterday with Ash Kalra, Miguel Santiago. And one thing they continue to mention is that we honestly have to give these assembly members and senators, we have to be their courage in a time where we know that money in politics is reigning unchecked. I understand why it is hard to go up on a bill that is considered controversial for the political world, because this is a multi-billion-dollar industry that we are coming after. And that is a lot of money, that is a lot of influence. And so what we need to do is, as we get more and more people on board, we need to show them love and let them know that the people have got your back, the constituents have got your back. Getting money out of politics isn't just going to be legislation, it is going to be the people showing that those people in these positions that we've got your back. We will show up with our vote if you do the right thing. You support us, we support you, and then you won't need to go up against all that influence. And so, yes, we need legislation that gets money out of politics, but we also will be there for them. And so I just wanted to share that. So as more and more people sign on, give them a little praise, give them a hand clap, tweet at them, Instagram at them, your appreciation, let them show that love. As we're going into a election year, if you're signing on to AB 1400. If you're helping us get AB 1400 through, you know, I have no problem showing up the text bank for you and Canvas for you. Throw a little money. I mean, granted, I have a full-time job, so whatever I can do, I want to show my support for you because you're supporting me through this, and you're supporting California, and that's what we need. So once again, that's why I said the list has grown and continue to grow. This isn't throwing shade if your name isn't on there. I just couldn't find everybody. All right, so here's support from around the state. Thank you to Public Citizen who put this list together because it made it very easy for me to steal. But I gave you shout out to Public Citizen. So these are the following cities, municipalities, or counties who are in support of CalCare. Look, City of Los Angeles. Hey, we're the biggest city in this darn state, and our city council voted to, you know, bring forth this. And I have to give a shout out to Healthcare for All Los Angeles, Chang Sim, Sean, DSA, all the other organizations who helped put that resolution through. Thank you to Mike Bonin, to Nithya Raman, for who carried this resolution through the city council. City of Los Angeles, second largest city in the country, supports single payer healthcare. Yeah. You've got, you know, the city of San Francisco, Santa Monica, San Jose. Santa Jose better support this, knowing that that's Ash Kalra's like home city. You know, you've got so many cities on here. Sacramento, the capital, supports CalCare. So, you know, the place where the big shiny building is that the Assembly and the Senate meet in is in Sacramento, and the people of Sacramento want CalCare. So your own house wants CalCare. So, you know, you better kind of listen to that house, right? I hope. Santa Clara County, Alameda, like we've got kind of some good support from across the state, heavy in the Bay Area. Shout out to you guys. Central California with Santa Barbara, and then SoCal. You know, we got to get a little deeper. We're going deeper south. We know behind the orange veil of Orange County might be a little bit of a challenge. Side note, I went through Orange County just on a drive and stopped to get some food, and I lost my mind because I saw people behind the food counter not wearing masks, and I lost it. I literally stopped so dead in my tracks, and it's just like the rules just from one county to another are so different here right now. Anyway, tangent, I'm sorry. So I just wanted to give that, you know, kind of like we are working, but this list is going to grow. It may have already grown. And so if your city's not on this list, hey, check with your city council, ask them, or do you support CalCare? I support CalCare. We need support of CalCare. The city of Los Angeles is supporting CalCare. So if the city of Los Angeles is doing, I'm not saying LA is the best place, but we are the biggest place. So I think every other city needs to join in. All right. So then, like I said, we passed rules committee. Hey, this is actually a really big deal, because in the beginning, we were like, oh crap, how are we going to get through these committees? Oh crap, we didn't know we had so much, you know, like we didn't know where we stood on support. And so we actually got the rules committee pretty decently. And so that's why I know that like all the people in the assembly, Ash and Miguel and Alex Lee, working their butts off trying to whip the support, you know, because I know last year they were saying that they were getting called communists by some of their coworkers. And now we're passing through committees. So I know that they have been working their butt off trying to convince their coworkers to support this. And we have been working our butt off making noise about it. So I'm loving the support right now. So here you see, we have people who voted yes. Richard Bloom, we were just in your district, friend. Kind of cruising through WeHo. You know, thank you for voting yes. Jim Wood. Now, this is a big one. Jim Wood, who is the chair of the health committee, who we will be seeing on Tuesday, has pledged support, said he will support it. And it's proven right here. He is also on the rules committee. So thank you for all of those who voted yes. Now, we've got some work to do. We've got some work to do on those who voted no. And so if you see, if this is your assembly member, one of your assembly members highlighted in red, and this is your district, feel free to reach out to them, not rudely, just asking them, hey, you know, what is it that makes you not want to support CalCare, and find out what it is and see if there's something that we can do to convince them, because we still need their vote. They may have voted no on the health committee, or excuse me, on the rules committee, but maybe by the time we get to the floor, we can convince them to vote yes. Not to mention, a lot of the people that are on one committee sit on several. So they may be on this committee, they could be in appropriations. We will need their votes. So if you have if you're a member of one of these districts where the person was absent, did not vote, or just plain voted no, feel free to reach out to them. You are a constituent in their district. And we have links for that, how to send a letter to your assembly member. Paul, I don't know if you have those up that you can drop them in the chat. We have a kind of like a bit.ly link where you just fill in some info and it sends a letter to your assembly member to asking for their support. So if they voted no here, we can change their minds by the end of the month where we need their vote on the floor. And if not, well, just know that we saw what you did. We know what you did in January, and this is an election year. That's all. All right, so ain't no stopping us now. We're on. Sorry, I heard that song on the radio, and then I was like, oh, that's perfect for what's going on. McFadden and Whitehead, just giving kind of rights. I would have played it, but I felt like Facebook would have shut off the live stream because of copyright things. So now you have to deal with my broken kind of like singing. But yeah, so ain't no stopping us now. We are on the move and we're moving fast. So basically what we need to do is get out the assembly by the end of January through the Senate, amend it, and we've got to get to Gavin's desk by September. During an election year. So, I mean, this is easy, folks. We're going to do this. All right. So we have health committee coming up on Tuesday, right? There is a link that we'll drop that you can send a position letter through the assembly portal in support of this. The witness, like open virtual witness kind of like opportunities, they stopped doing that at the end of, like, you have to submit that you would like to be a witness or to make a statement. Testimony, that's the word, sorry, testimony. You have to do that by the Thursday prior to the committee. And unfortunately, we didn't really find out that we had passed rules until like Thursday. So it was like, oh crap. But you can still submit kind of like a letter of support. So, and this portal that you do this through, it literally is for registered lobbyists, organizations, and individuals. So your lobbyists, your insurance companies are doing this right now. Trust and believe it. They probably took up all the witness spots too. We'll see how that goes. We'll see when we watch the hearing. If you can submit a position letter of support for AB 1400 for the health committee on Tuesday, it'd be really, really good. I know it's Sunday, but just saying, please support AB 1400. That might be all the thing you need to type, that would be fantastic. So health committee. After health committee, we're going to appropriations, and then we're going to the assembly floor for the floor vote. That has to happen before the end of January. So we have to get through these by January 31st, the last time. And so if we get through that, we're back kind of starting off, we're at the Senate Rules Committee. We're kind of going again through the Senate, kind of the same process. We're at Rules, we are at Health, we're at Appropriations, we're at Senate floor. We get through that, here comes amendments. And so we know there's going to be amendments. I think a good question for us to ask is like, what are we willing to negotiate? Now, truthfully, nothing. I want this all. I want to be all or nothing. I really do. But I'm also realistic. And I know for some reason, I feel the weight of 40 million Californians. And so I will not let this bill die to be a stick in the mud. If there's an amendment, they want to redo something, or they want to maybe kind of tweak something, I'm not going to completely put California, in front of the train there. So I want to, that would be a good discussion. It's like, well, what is it that we are willing to negotiate, to say, okay, to get this through. But I am not willing to see what happened to the ACA happen again. This will be single payer. This won't be public option. This will be single payer. Your insurance companies can go find and create themselves a cosmetic plan so that everybody who wants to get the mommy makeovers and the BBLs and the breast lifts and all that stuff, they can buy into an insurance program, and then you can do that. So I'm willing, that's a negotiation right there for the private insurance companies. I think I'm willing to have an amendment in CalCare that private insurance can create a cosmetic buy-up plan if they want to still make money. amended, done. And then it goes back. So after the amendments and they agree on it, it goes back to the assembly for concurrence. So the assembly has to agree on the amendments and re-vote again, and then go to the governor's desk. Did I skip anything? I think that was it. I think that's it. Okay, so then it goes back to the governor's desk after the concurrence happens in the assembly again. So it sounds like a lot, and it is a lot. These are very big hurdles that have to be jumped. Every single one is going to be big, I will not lie. But every single hurdle we jump gives us so much more momentum. I don't know about you, but when we passed rules committee, my energy shot through the roof. Like I was out yesterday in WeHo at our CalCare caravan. And I know that the 16 of them occurred across the state of California. So you probably saw people honking and looking crazy in their cars painted with, CalCare somewhere throughout the state. So every time we jump a hurdle, the excitement, the momentum keeps building. So every time we hit a win, the momentum builds and builds and builds and builds. So it looks like a lot, but that energy is going to keep building. We haven't even reached the fever pitch yet. The fever pitch really should be happening when we get to Gavin's desk. But so I just want to sit there and say, don't look at this like, oh my God, this is impossible. It's not impossible. It's very possible. Just know that this is your bill. This is our bill. So this is California's bill. This is not Ashkar's bill. This isn't Gavin's bill. If he wanted it to be his bill, it can be though. If he wants to call it Gavin Care and that means he'll sign it, I'm totally down, totally down. You can call it Gavin Care, just sign it. Just be in favor for it. Gavin Care, whatever care. It can be your care. So, I'm totally down for that if you support it. So, that is what I just want to emphasize. So don't get distraught. Don't feel like there's too many hurdles. This is fine. We've got this. Okay, and that's my 2-second little presentation. All right, I'm gonna stop sharing. Erica, Maureen, I know you guys are on. Do you guys have anything you want to update while I get a drink of water?
Yeah, I would just like to say that was awesome. Thank you so much, Jeanna. And it's so fantastic to see Dr. Ron Birnbaum here, because Dr. Ron Birnbaum, this is his baby, office hours. He conceived of it. He started it. He did it week after week after week for months on end, along with Jeanna. And we also had Dr. Bill Honigman join, and Dr. Richard Wynn, and, the usual suspects from Healthcare for All, James and Erica and Paul, and, so anyway, it's so great to see Ron. Hi, Ron. Yeah, I just have one update, and that is I just found out today that Martin Luther King Day, which is Monday, January 17th, there will be a Martin Luther King Day car caravan, and we have been invited to participate for AB 1400, and they have given us a flatbed truck, which is kind of cool. So to hang our big banners on. So I'm hoping everyone that is on this call can make it. Just make sure, send us if you're not already connected with us, please send us your information. You can send it to info at what is it, HCLA.org, and let us know, because we'd like to have a really big contingent for AB 1400. We will gather at Western and MLK Boulevard at 9 in the morning and 9:30, and take off at 11. It is actually going to be a parade as well. They have at least one 30-member band that's going to participate, standing 6 feet apart, but of course no mask for the brass. Pretty impossible. And we hope to do our staying alive routine. We're checking that out with the Feel the Burn crowd, who is so wonderfully creative. So that's my big announcement, and hope you can all make it. I know Jeanna will be working hard, saving lives, but that's okay.
Well, I just have to say, go ahead, Erica.
Sorry, just a couple of things, and then we do have questions I'd love for you guys to answer. But as Maureen said, Healthcare for All Los Angeles is co-sponsoring the Martin Luther King Coalition's event. And if you are interested, you can email us at info@hca.la@gmail.com. January 12th, CNA is holding a call about financing. So I dropped the link earlier in this Zoom chat. Paul Newman can find it and redrop it in the Facebook comments. But that is January 12th at 5 p.m. So we'll drop that registration link again for that. I just dropped a Google Doc where you can find a list of all the healthcare committee members, so that's what's next on the docket, and all of their contacts. Paul will drop that in the Facebook comments. You can call them every day. Every day. It's not that many days. The hearing's Tuesday.
You have Monday.
So call them a couple times on Monday, call them Tuesday morning. And then we do have the letter to sign in so many actions. All of the actions can be found at our toolkit, which is bit.ly/HCALA toolkit, all lowercase. With that though, I know Jeanna, you were busy presenting, so there's a couple of questions.
I
Dr.
want to clarify one thing. The sponsoring organization this year is the Harriet Tubman Center for Social Justice. It's not the MLK Coalition. They will participate, but the organizing group is the Harriet Tubman Center for Social Justice. They are a national organization, and this is a Los Angeles chapter. So just to clarify that, and we are co-sponsors.
Okay, with that, thank you. Let's get to some of the questions.
Well, actually, before we we're gonna go into questions really quick. But before we go into the questions, we will, at the end of this, we're gonna go back over actions. Thank you guys for sharing that. And so we will go over, what actions we're going to be doing again at the end. I did, if you're not sure who your assembly member is, I did put a link in the chat here to find out who is my assembly member. And that's perfectly fine. So I put a link in the chat there to, allow you guys to find out who your assembly member is, so you know who to reach out to. And then also, I just wanted to kind of like share why CalCare is important. It's kind of like when you have someone who codes, you have these links of survival, mainly pre-hospital, but it's same, you run the same in the hospital, very similar. And so you like activate a code, right? You're saying, oh crap, something's wrong. This person's like turning blue and they're not breathing. And you activate, right? And I think we have activated. We've been activated for several years. We've realized that, that the healthcare system is inherently flawed and that it needs to be fixed. And they've attempted to fix it, kind of, which to me would be kind of the early CPR phase. So we started CPR. We started kind of doing some things. We started with, trying to correct things like, there was Medicare, and then they kind of did Medi-Cal, and they did CHIP. And then, so we've been kind of like doing CPR on our healthcare system almost since it started. And as I told you in the beginning, doing CPR is exhausting. That's why we're trained to switch out after every couple of cycles, because it exhausts you. It is physically taxing. And we've really been doing CPR for a very long time. And I mean, by decades. And so then here comes the ACA. So the ACA was kind of like your first shock, your defibrillation. I got a defibrillator finally. I'm getting ready to shock this country and get them the healthcare that they need, right? I thought. Unfortunately, no. So our first shock kind of failed. So I'm charging again, and now I'm ready to give the second shock. The second shock is usually a little bit more powerful because we're trying to actually get the heart to beat again. We're trying to wake up that electrical, we're trying to get some electricity going here. And so now I'm getting ready, I'm charging, here we are. I think we're kind of in this charging phase with AB1400. I haven't quite yelled clear, Haven't gotten that point yet. And when you yell clear, the funny thing is you want to make sure you're truly clear, because if you're like laying against the bed, if your knee, like I was an EMT when I was a baby EMT, and my like knee was still slightly touching that bed, and they shock someone. Look at Ron's face. He knows what happened. And it was electrifying. I'll just say that. And so I haven't quite yelled clear. So we're kind of there, but then you have 3 more links: advanced resuscitation, post-cardiac care recovery. Those are your links of kind of your chains of survival when it comes to providing like CPR for patients and advanced cardiac life support. And advanced resuscitation would be, okay, we got CalCare passed, we're kind of building it out. Now we're doing some really big things. We're intubating, we're pushing all these fancy medications to get the heart going, to get the circulatory system running again, basically save your life. Come back from the white light is what we're doing. We're pulling you back, come back from that white light. And so we're in that phase. So we're getting ready to yell clear. Clear would be, hey, we're going to the floor to vote. So that's our clear, because we can't do anything. At that point, when we yell clear, the only thing you could do is hope that shock worked, right? And so that's where we are right now. We're getting through the committees. We're kind of defibrillating. We're charging again for that second shock. And when we hit that assembly floor, clear, and we're going to see if we did anything. We're going to see if the heart stopped, or excuse me, the heart restarts. There are times where we actually want to stop the heart, but that's a whole nother story. When you have like some funky rhythms going on, we actually do want to restart your heart in a different way. Anyway, not to go down those tangents, but I now do want to get into questions. That's what we're all here for. I just had to share that because I didn't want that thought to escape my brain, because I knew it was something funny. All right, so I do see a hand up from Jeffrey. So if you have questions and you're here in the, Erica, I know you've been watching the chat more. Were there questions prior to Jeffrey's hand? Just to be fair.
Yes.
Oh, okay, sorry. Hold on to that thought. Jeffrey, we're gonna come back to you.
I'll feed you the question. It came from Facebook. I thought Dr. Ron might want to take this one. From a gentleman named Wayne, and he actually has 2 questions, but the first one is, what happens to Kaiser Permanente when CalCare gets in place? Oh, I'm asking you to unmute, Ron.
Uh-oh, you muted again.
Here, how about that?
Yay!
Super nice to see everybody here. I'm
so excited.
So much work's been done. That is a good question, because a lot of people in California get their health insurance from Kaiser, and to get at what that question is about is to understand what Kaiser is, and it is a set of hospitals and a delivery system of care, and it is also a health plan, and those functions are separate. That delivery system is also like has a kind of the pays a bunch of doctors and other people, and the answer is that the health plan part of Kaiser would go away, or I guess would say would be superseded by CalCare, by one single payer for the whole state. But all the hospitals and all the people who work at them and all the places that people either like to go or don't like to go, depending on what their experience is, will still be in place. And but there will be some rules that govern what they do. They can't they can't kind of create things like profit by restricting care or by limiting what people do. So they can, so there'll be some differences in how Kaiser works, but it would be wrong for anybody to say Kaiser goes away because of this bill.
Nope, just the insurance part of it. So the Kaiser Insurance Company for California, Kaiser's big. Kaiser is not just California. So for California, we are going to say, thank you for your service. We appreciated what you've done, but we have decided to build something a little better. And we're going to kind of try that one out now. But we're going to keep your hospitals and all your care, and we're still going to pay you. You're going to get your money. It's just that you don't have to regulate that anymore. We got this, homie. We got this, basically.
I wanted to make one comment about the advantage of AB 1400 and Kaiser, and that is there will be no more networks, right? So an HMO requires people to be in their network. So we're removing that. So if I want to go to Kaiser for orthopedics, and I want to go to Ron Birnbaum, wherever he is, for dermatology, and I want to go somewhere else for, maybe St. John's or Martin Luther King for something else, I can do that. And right now you can't. Right now you have to be a member of Kaiser, and there's no more membership. You are a member in CalCare for the entire state, meaning you can go to any hospital, see any doctors, go to any facility that you choose. So Kaiser cannot exist in the way it does now because Kaiser needs members who pay premiums, and that's not going to happen because there will be no premiums and there will be no deductibles, and most likely, unless it gets amended out, no copays. So anyway, that's one of my thoughts about Kaiser. The advantage is that we want freedom of choice. Patients need to be free to choose where they want to go and who they want to see. And we cannot have HMOs operating because they obstruct that.
Thanks, Maureen. Eric, I think I see the next question from Wayne about is it about the government? Okay, so Wayne asked from Facebook, historically, government hasn't proved capable of managing a program like this. How is this different? Well, actually it has. Medicare. And the problem is that Medicare has been pinched a lot. So the government has managed well. Medicare since 1965. And even with government shutdowns, Medicare didn't go away. People's Medicare coverage didn't stop. And so, yeah, it actually can do things right. It's honestly, it's the leadership that is the problem, not the program itself. So yes, with AB 1400, it will be different because I think our eyes are open. The pandemic made us go, whoa, this is crazy. Right now we're going, whoa, again, because it's like, why can't I find a test anywhere? What is up with that? Why did it take me 3 days to get cleared to return back to work? Because I couldn't find any testing sites, and we had them everywhere and they disappeared. So it's kind of like, it's not necessarily the programs, it is the leadership. And I understand people's apprehension. I am apprehensive as well, but to protect CalCare, to protect the work that I have put in, because I so much so am a lazy bum that likes to lay on my couch and watch Simpsons all day long. And I have put in a lot of work to this to protect this program. I am willing to go out and vote. I am willing to make sure that those people I put into the Assembly and Senate of California, the people I put in as governor, the people I make sure are on these health committees are people that will continue to let this program thrive and grow and will not have a corporate interest to penny pinch it or to privatize it. And that's what happened. So to answer your question, Wayne, it is a reach. I understand. I don't have it guaranteed, but I think our eyes are open now and you see how many cities full of activists have been fighting to get this on. So I think we get this passed, we get this actually going, we're going to continue to fight. We're not going to be like previous times where we got what we thought, we got what we wanted, so we went to sleep. There's no more sleeping. The giant is awoke and the giant is angry. The giant wants to get what's theirs. And so we're going to continue to be here for it, even after CalCare is signed, because I know Governor Newsom is very excited about it. Speaking that one into existence. But I know I'm sure he'll be excited to sign it by the time it gets there. And so I just wanted to, so that's how this will be different. But yes, the government can manage it. We just have to make sure the people we put into those positions are those who will support it. just want to go through really quick and just make
I
sure.
just wanted to see if Dr. Ron.
Yeah, Ron, do you have
Now in my head, Ron, the song in the Navy is popping up. If you wanted to add anything to that.
No, well, I think Jeanna made a beautiful answer there. But, you know, like we all have, I mean, Wayne, if you're out there listening, like, I think everybody here, you know, everybody's had some experience where they went to like the DMV and the line was long, or something with government that didn't go super well. Although maybe you also have had some, you know, other really good experiences, like you know, the medical school that educated me was run by the University of California, or I just went on a trip on a camper with my daughter, and I went to the public library and got 6 DVDs out, and they were all free, and they're doing a beautiful job down there at the public library. So actually, I'd say people have a range of experiences. But I think what maybe you're hitting on, or maybe it's important to understand, is what CalCare does is it creates the kind of the government as one insurance company, but it doesn't mean that the government is operating all of, you know, every clinic and every hospital or everything. Those are still just run by either, you know, some places in the public sector, some in the private sector. They stop being able to be for-profit institutions, and I think that that's really important. But still, the ingenuity and the creativity and the leadership ability of people like Jeanna, who run, you know, operations on the ground, doesn't go away in the state of California. So I think that that's an important thing to grasp there.
And I just wanted to add before we, I know Maureen, you wanted to add to that, and then we're going to get to Jeffrey. So right now, when I'm arranging things for patients for them to discharge, sending them to nursing homes, getting them equipment, doing whatever they need to get home and be happy, hopefully happy. When I'm working with vendors to get this stuff done, if I send out a referral, the patient has Medicare A and B, right? Just original Medicare as it was signed in 1965. I get responses like, boom, that Jeanna, hey, Jeanna, you still have that patient? I could take it. We can accommodate that patient. Hey, Jeanna, when do you need this delivery? I can deliver to the hospital, and, you know, we're right around the corner. I'll be there in 20 minutes to deliver that walker for you. When it's Medicare, when it's Blue Shield, I ain't getting a response. When it's Blue Cross, I'm begging people. And you want to know why? Well, Jeanna, Blue Cross doesn't pay. We haven't had our claims paid by Blue Cross for a while. So with Medicare ran by the government, this is true facts. I can bring my coworkers on to corroborate this. True facts. Medicare A and B, I got things done. Like, I don't even need to worry about it because I know I'll have it done ASAP and right then and there. But when it's a plan, when it's managed Medicare, managed by one of the health plans, or you're a PPO with one of these health plans, I'm having to get on the phone and start yelling at the same people who just called me 20 minutes ago, telling me they'll take my Medicare patient, but won't take the Blue Shield patient or Blue Cross patient or anything like that. Or I have to get on the phone to Kaiser because Kaiser sent their patient to my hospital for higher level of care. And now I'm on the phone with Kaiser trying to get Kaiser to approve something. And so you see the difference when you have a single, like, publicly funded program like Medicare versus when you have the private coverage. I have to work a lot harder to get you what you need. The public coverage, the people are coming to me trying to get you what you need. They're like, oh, you got Medicare? Okay, hey, I'm ready for whatever. What do you need? I literally have text message, Jeanna, we can take this patient. What do you need? I'm on site. I can go do teaching right now. Like, they're begging me for these patients. But if it's a plan, I'm begging them. What's up with that? All right, Maureen, go for it.
I just have a couple of things to say. The VA, being a publicly run program, actually has great satisfaction polling, and they also have very good outcomes. One of the things the VA does especially good that private insurance does not do is that the racial disparities disappear in the VA. The outcomes for instance, African-American patients and with cardiac issues is better. I mean, it is better than African-Americans results out with the private insurance system. You see the disparities, and actually they do better than a lot of the white VA patients. There's been some interesting research on that. I wanted to point out one other quick thing, and that is the private insurance has been running our system for, 100 years. Where are we? Where are we with that? We have people going bankrupt. We have medical debt. No other country has medical debt that has single payer. It's unheard of. We have people losing their homes, people being foreclosed on. We have people being denied care, delayed care. We are #1 in the world for preventable death. That means if you were lived in any other country, you're much more likely to stay alive than if you're in the United States. We're also #1 in preventable disabilities. We have more and more people disabled. You look especially at diabetes, which is in astronomical numbers right now. People can't afford their insulin. And they also have to wait weeks and weeks for appointments. By then they need an amputation. We have record numbers of amputations in this country that other countries don't have. So this is the private system, folks, and it's not looking very good, okay? So a quick metric. Insurance is about making money. It's a business plan. It's not a health plan. Their only goal is to make money. It's an extraction away from our delivery of care, the resources. Healthcare is an infusion of resources, an infusion of our tax dollars for our care. So for health insurance to be successful, your health care has to suffer. And for health care to be really successful and do a great job, your health insurance business plan, they just can't quite pull those profits in. So that's one way to think about it. Insurance and healthcare are absolutely opposites. They are absolutely opposite of one another.
Thanks, Maureen. Yeah. And this one, opposites don't attract. All right. Thank you for being so patient, Jeffrey. Go ahead and come off mute.
Well, I also participate in a number of other coalitions. I hope you can hear me clearly. So we have for this one is the AB1400 that will be at 1 o'clock or so on Tuesday. But there is an equal concern on Wednesday morning at 9 o'clock in the morning. There is elections. It's having before it a bill 1416. So please invite people to look at the assembly bills and hearings that are taking place going on this year, because there's a number of other matters that all have to get taken place and go through the assembly houses by the 14th and by the 21st. So I just invite people to look at that. And the reason I bring up this clean money, which is down there in LA of Trent in Culver City for clean money campaign, is this is what we observed happen last election, where trying to get the AB5, where money came in and basically change that where it was what was wanted to be and happening. And we are going to have enormous amount of money of the insurance companies that are going to want to do everything they can to misrepresent this. And this is why this disclosure bill is important, because it's saying that on your ballot measure, these are the people, and whether it's the healthcare, the nursing association, or something that's supporting it, it puts it out there. Just like for those that are putting the money the other way, it puts it out there. This is being supported by a dark money campaign, whatever is listed. It's just a comment right now that we have this week a number of things, but the most important line is getting by on the health committee for 1 o'clock on Tuesday. And get in there beforehand, because the telephone system in the new building is not necessarily the best. The phone numbers get crossed over at times, so you don't get who you're talking to. Anyway, that's my reminder to you guys for what's going on this week. Look up and see the assembly bills that are going before hearings. Thank you.
Thank you so much, Jeffrey. Actually, Trent Lang reached out to me regarding AB 1416 because my assembly member, Isaac Bryan, is now the chair of the elections committee. So I'll be on that call, you know, and helping to, you know, get that going as well. So I am paying attention, you know, to the other bills, of course, AB 1400 being my primary, but, you know, as much as we can, I know, help out with other legislation. I know several people are part of so many different things. Okay, so Isabel, I know, I just want to go, there's a question from Wayne that Ron's going to take, and then I'll come right to you, okay?
Well, Wayne's was like a follow-up question. And so if there were others before him, I think
that was it. And then
go ahead. Okay.
Hand up. Yeah, I think.
So let me read his question because it came to us, I think, via Facebook. And thank you, Paul Newman, who's been monitoring the Facebook and putting the questions in the chat here. So for everybody out there, Wayne's question or next question was my first. I'll just read it. My first issue is nobody forces one to become a member of Kaiser. The beauty of Kaiser is that all your medical records are contained within the Kaiser system, so all care is coordinated. How will this work under this plan? So, so there's a lot in this question, and so I want to say a few things there. So first, it is absolutely not true that nobody is forced into being a member of Kaiser. There are, and let me also say that there are people who are very happy with Kaiser and people who are unhappy. It has all of the above. But it is the case that many employees of many companies have one choice, only one choice in the health plan that's available to them. And in many places, that's Kaiser Permanente. And so it is not the case that people are just like only choose to be a member of Kaiser. And then Wayne goes on to talk about the beauty of Kaiser being that all of your medical records are contained within the Kaiser system so that all the care is coordinated. And let me say a few things about that, which is that one thing I sometimes in some of my work see people who are very unhappy, who are unhappy about their care at Kaiser and couldn't get stuff to happen for them in that system. And then they just came to pay out of pocket to see, in my case, a dermatologist to help them with a problem that wasn't being addressed there. Sometimes it's just a matter of navigating a system, which can be a problem all over the place. But that Kaiser does have a single coherent record system, but our system on the whole has barriers between the sharing of records exactly because individual pods within the system don't want to share records. They want to make it hard for you to get care in other places. So
the VA doesn't share their records at all. I just want to add that you can't get records out of the VA. Don't even try.
Right. Now, it turns out there's a federal law called the HIPAA, which is there to try to make it so that places have to share their records, but it's still like not the case that it's easy to get them. Now, if you stay within that system, of course, your point is right, that some of Kaiser's successes come from its having some coherent medical records. It's not the perfect health record system, but it's okay, it's pretty good. But if we go to a single payer in the state, we will have eliminated the big financial incentives against interoperability of record systems, because nobody's no longer trying to hoard patients in the way that Kaiser does.
Right. And Kaiser does use the Epic system, which a lot of other systems do. And Epic does have a care everywhere feature so that they are trying to meld together that access. But once, like Ron said, they limit it. So for Ron or myself who wants to see your other history, I may get hit with a wall. Saying, okay, well, it's there. I see you that you were a Kaiser patient, but I can't still see your records, even though I'm a care provider logged into this system. But we could possibly build out or the state of California may contract with Epic And then if the state of California has a contract with Epic, because the California, I don't foresee us building our own EMR, even though we could, because we have Silicon Valley right here, probably be a great project for them, but I could see that we would be working with organizations as well to get this started at least. So like maybe there could be an Epic for California where we would have all your resources, all your CalCare under this one roof. I can see that happening, but how and all of that, like I said, I'm not, too concerned about like there being a breakdown in records because, well, there already is. Sorry, Ron.
No, you got it.
All right. So now I want to go over to Isabel.
Okay, I'll unmute. Yeah, so my main questions have to do with activism and getting this passed. I have outreach to other groups, especially Indivisible statewide. So I want to disseminate, what we can do now. I know we have the hearing coming up on Tuesday, and it looks like the main things people can do is call their assembly members. And I didn't know you could submit position letters as an individual.
Nobody did. It's such a secret. I put that link in there. I think this is the portal the lobbyists use.
Yeah, because
that's why I put that link in there.
Group. But anyway, individuals, but then I think Jeffrey was talking about calling in. So are we talking about calling in just to their offices, or, last year when there were hearings, there were Me Too's where you could call in to support legislation. Is that still happening anymore, or is that?
So I went on the health committee site, and actually I'll share, I have it up right now, so I'll just share it. Maybe, possibly. Oh, I'm trying to do things so like real time, and then Zoom is like, no, I'm going to make you look stupid. Okay, here we go. Can you see, Isabel? Can you see this?
Yeah.
All right, so here's the Committee on Health. So it says, that to be a witness, right, to basically be heard during the hearing, you're supposed to email the the committee secretary by the end of the day, Thursday before the hearing. So this would have been the previous Thursday. And unfortunately, a lot of us didn't know we hit health committee and we made it past rules until Thursday. So now, just for future reference, we need to look at the rules for the appropriation so that we can get more people in on to make those to be actually included in the witness testimonies. But then here's this link: position letters are due the Wednesday before the hearing by noon. I kind of like, well, we weren't even in the committee, so I am advocating for people to click this link here, which is the link I dropped, and it takes you to this portal. Right. And this is like any legislation. So I'll click it because I'm already signed in. So here, when you create your login, so you select the bill. So you type in, 1400 and search. And then here it is, the bill, right? It's in health. And then you select your support and you just type what you type what you want, or you can upload a letter, you hit submit. That's that.
Okay.
So yeah, so I'll drop the link again and I'll drop the link directly to this page right here, so that, to me, going the most direct is the best way to go. So if you want to share it, but like I said, I don't know how many of these will be accepted, because technically, just like it says here, it was supposed to be the Wednesday before the hearing by noon. So that would have been last Wednesday. And I just don't think it was fair, because I don't think, when did we get out of rules committee? Was it last Tuesday or last Wednesday? So, and we didn't know, we got the update on Thursday. So yeah, if we're going to move like this, it's kind of hard. But I think now, knowing that we are moving this fast, I think people can start submitting things to appropriations, even though it's not on the schedule yet. So I'll drop this link again. And Paul, maybe if you could drop it into Facebook, that would be good if people want to submit a position letter, even though, like I said, I know we're past the deadline, but at least they're going to see that we are watching and we know when we are figuring this out, we're knowing their processes now.
Do we know if that's a vote on Tuesday, or if that's just when they start? And I know we have till the 14th that it has to pass.
I believe that they're going to vote on it on Tuesday.
Okay. All right.
Drop that link.
Thank you.
No problem. Erica, and then I see Jeffrey has his hand up.
have so many things and questions, but I want to follow Isabel's lead there to start with. Jeffrey, you talked about the hearing on Tuesday for the Health Committee. Is there a way that we can tune in? And if so, can you drop that information in the chat?
I will call tomorrow morning and get further out of Jim Wood what's going to happen in the manager, the exec on that. Because I don't have it right now sitting in front of me, but I do know there has been a problem with the electronics, and some of us are planning to be there physically, and we'll see if we get into 4202 to testify.
Okay, that's great. Yeah, and I'm seeing confirmation from Chung Sim that it is a hearing and a vote in the Health Committee all on Tuesday. And I think, Isabel, like when we get those dates, you know, like how it says January 14th, I think those are like projected dates. So like for the Rules Committee, it was, you know, we had been given the date the 3rd, but they couldn't fit everything on the agenda. So AB 1400 got pushed to the 6th. So just, you know, you got to take it with a little bit of flexibility there on the date. So it looks like this one got moved up. But again, everyone, you can call the members of the Healthcare Assembly every day. What do I mean by every day? Oh, that would be one day in the morning of Tuesday since we're there. And where can you find the list for the Healthcare Committee members and their contacts? Why, you can find them in our toolkit, and that's bit.ly, bit.ly/HCALA toolkit, all lowercase. So
I'm just going to speak up here. I just looked on the website and it gives a URL to watch the hearing.
Yeah, I was actually, Isabel was right there with you. I'm dropping it in the chat right now. Yeah, I was looking at, I was like, I know you can watch it. There's a link. It's not live right now, of course, because there's nothing playing, but I'm putting the link, and Paul, if you don't mind dropping that into the Facebook. And I think maybe we should this would be a good one to even add to our toolkit, huh? Well, I don't know. It's just Tuesday. It's just because this goes directly to only Health Committee. So I think that, you know, we may have to figure out a way how to add that into the toolkits for each committee. Appropriations coming up next.
I'll have that added to the toolkit before this office hours is over. So thank you, Jeanna, and thank you, Isabel, and thank you, Jeffrey, so much. The other thing that I just wanted to touch on is, you know, just back to the conversation earlier and about Kaiser and the One Network and the records. And Ron, you know, and I know that Maureen has had experience with this because she's had family members in Kaiser. It has been my experience and others' experience where, I mean, it's like the Hotel California. Once you're in, like, you can never check out, even if you want to check out. And it is so difficult. And I liked, you know, just referencing earlier, because I think I'm not unique, but if I want to see Ron as my dermatologist because of his stellar reputation, I want to go see Ron. I don't want to be stuck, but maybe in Kaiser, if, you know, like Maureen said, the orthopedist is amazing, then I lucked out. But I don't want to be, you know, we say we love freedom as Americans. I want the freedom to go to the doctor, to the therapist, Jeanna, the one that, you know, it didn't take your insurance. I want to go to the professionals I want to go to, you know, the ones that I connect with and have researched. And so I just had to go back to that. And then I just wanted to open up because Chung Sim, you also made a really great point. I don't know if you're available to articulate that out loud. And if you are, I just invite you to unmute and share what you wrote in the chat. And if you're not, I can say it for you.
Just really quick, I just want to, going back to the health committee thing, I do want to let people know, for all of you watching in Facebook land and here, AB 1400 is the last one on the hearing list because it was just added. So there are 12 items and AB 1400 is the 12th. I'm hoping that we will they'll get through the rest of theirs. I'm looking at some of what's on there right now. And I'm like, if they keep trying to do stuff with skilled nursing facilities. And I'm like, well, you know what the thing about skilled nursing facilities is that they're extremely for-profit. I worked for one of all of 3 months and it was so despicable to me. I threw my badge at the DON's head. And that's the only place I've ever quit. I've never quit, I never just walked out of a job until I had to work at a SNF. Very for-profit. Anyway.
That's such a good point, Gina. And again, this is another thing. CalCare gives long-term care for disability, long-term care for aging. And basically it takes the profit out and by doing that, it puts the healthcare in. You know, if you look at like, let's say the UK's, oh God, I'm going to get myself in so much trouble, but the vaccine schedule that they have there, I'm not talking about COVID vaccine, I'm just talking about regular vaccine. I have 2 kids, you know, they believe in vaccines, there's vaccines, but it's different than it is here. And I think that, you know, and speaking of COVID vaccine, we have a huge issue with people trusting the vaccine or not. And we have a doctor and a nurse that will tell you, trust the vaccine. I've been vaccinated, but I'm just saying, I understand people's distrust because for-profit has made things, you know, people question things. And once you take that out, you build in more trust. Now, having said that, please get the COVID vaccine. I was not saying anything anti-vaccine. I was making a point about trust. But I'm going to articulate Chang Sim's point since she hasn't unmuted. And she said, the inoperability among fragmented health systems is proving to be a big problem for the state in dealing with COVID, which is another reason for CalCare for us all to be under the same system instead of these proprietary systems that once you're in, they don't share or they make it very difficult. And Gina, I know you were talking about Silicon Valley. Hey, in France, you get a card. Here you would get a CalCare card. And on that card, it's all your stuff, all your medical visits, medical records, prescriptions. You know what? We don't have to invent anything new. There are countries that have been doing single payer healthcare for a long, long time. And in France, they got the card so that, you know, it's all there. So we don't need to invent anything new. We can just be like, give us the technology, France, and we've got our CalCare card. So thank you very much.
And I just wanted to say also, you know, Finland, #1 education system in the freaking world. So stay warm up there, Finland, but you know what? You guys are smart. They have one public education system, no private, no charters, one public education system. The rich kids go to the same schools as the not so rich kids, go to the same schools as the poorer kids. Everybody invests in one system, #1 education system in the world. And they don't really believe in homework either. And still #1. So I just want to say, you know, if you have kids and they hate the American education system, check out Finland. #2, that lets you know when you are collective, we're not so individual. When we believe in a collective community, we actually thrive all together. Rich, poor, you know, no matter what your color is, just like in CalCare, the basic principles, no matter what your color, no matter what your gender, you know, no matter where you immigrated from, we are one collective system. And when we believe in one collective system, we put all of our little pennies in one collective pot, we become #1, like Finland. Anyway, Jeffrey, I saw you have your hand up, and then we'll go to Maureen.
I'm just going to remind you, for you getting on to the system, because this is the last bill, if somebody could coordinate and say when it's coming up, it would be great, so that you're not on there from 1:30 or 1 o'clock until 3:30, 4 o'clock. I've been on sometimes 6 hours. The other thing for the phone system with an AT&T, punch in 0 so you find out What is your number? Because they typically use a number system to bring you up to talk unmute. That's for Tuesday and probably also for Wednesday. The Assembly do it one way, the Senate does it another way. And the agenda should be out there posted for the thing that somebody's reminding you about right now.
Thank you. Yeah, the agenda here, I'll drop the link, Isabel, and then Maureen, go ahead.
Yeah, I wanted to make 3 quick comments. The nursing care facilities for seniors are primarily private, and the people who own them and run them do not have to have any medical experience or any degree in healthcare or medicine. And a lot of these,
I personally know that.
yes,
I
they
can tell
have
you that's true.
absolutely no knowledge of what it takes to take care of someone.
They have MBAs though. They do have MBA. They
Oh,
have
yes,
some
MBA.
type of
They know how to
financial
extract money.
degree.
That they know how to do, you know, feed the seniors porridge, right? With like lots of salt, so they kick off on money.
Wow.
But anyway, that's one comment. And these facilities, they will be, there are only, the regulation is very, very lax because there's been cutbacks in the regulators, the people that visit these facilities. And at one point, a couple of years ago, there were 300 nursing facilities and only 3 inspectors for the entire county. And I talked to one of the inspectors, actually she came to talk to us, and she told us that there were problems in every single facility and there was no way that she could get to them all, and they were serious, but she had to prioritize. So as a senior who may end up in one of those, actually everyone here may end up in one at some time, we don't know. We want them to be good and high quality. We want some standards, we want some regulation, and we want people in there who are not there to make the bucks, but who are there to give care. And quickly about the ER, the fragmented system that Cheng-Sin brought up is very, very important in the emergency department. Time is wasted. Time is wasted. ER doctors have to have their staff, they have to find where the patient needs to go. They can't just say, this person is in acute distress, they need to go immediately, you know, we're going to stabilize them, they have to get to, you know, a facility. They spend hours figuring out where the patient needs to go. And we saw a tragic case of this at Martin Luther King, when there was a toddler there who was actually a Kaiser patient, but the mother brought him in acute distress. And we spent all this time with Kaiser, back and forth, back and forth. They said, we want to hospitalize him. Kaiser said, no, it's our patient, send him to us. So it was a 3-year-old. They sent him and he died in the ambulance. Okay. That's really unacceptable. So this fragmented system where you figure out, well, where do they go? Well, who owns them? Well, who takes care of them? That's absolute nonsense. Good healthcare is getting what we need when we need it in the way that we need it. And then my very last point was about, you know, the fragmented system. That is apartheid. It is a caste system. It is, you know, some people's lives are worth more than others. Separate is never, never, never equal. It's absolute nonsense that separate is equal. It is not, especially in healthcare. And one point about AB 1400, that one system puts the governor, my assembly member, your state senator, the unhoused person on the street, your grandmother and my grandchild, all in the same system. And when we are in the same system as the governor and the assembly members and the Senate, let me tell you, we will have everything we need, and it will be the highest quality, and it will never lack for funding. So that's the guarantee. Someone earlier was saying, well, how do we guarantee that this stays good and that it's going to be right and we're going to get what we need? The way we do that is to not allow any separate pay-to-play system where people buy their way into something else, because the people buying their way into something else are the people who are making the decisions about what the rest of us get. So
Except if
we
you
cannot
want a
have
Brazilian
that.
butt lift. If you want your Brazilian butt lift, your mommy makeovers, your, you know, collagen injections,
Yeah.
you know, all of that, even though Erica, I know you said Botox is a need. Only in certain instances is Botox a need. There is some very small, this big of a window where Botox is medically necessary. Ron, he's shaking his head. And if Botox at that point, you have that condition, I forgot what it is, that where Botox
that's
is
usually gynecological, the Botox that is necessary. Okay.
But if it's,
It's on the other end.
if it's medically necessary where we have to use Botox, okay, fine. But if it's because, okay, I'm trying to defy age, no, yes, migraines. And so things like that. So if you're trying to defy age, even though Erica's only like 35, like, me, then no. Yeah, so thank you. Hyperhidrosis, there we go, because I actually have that. I actually have hyperhidrosis in my hands and feet. That's why they're all sweaty now, even though you can't see them. And I just don't want to do it because I'm like, I'd rather just deal with the sweat than the things that could come with all that. And so, then yes, medically necessary, but it's kind of one of those things. I don't know. I've been dealing with that my whole life. I'm fine with it. You just shake my sweaty cold hands. Cold hands make a warm heart. That's the key. And so, yeah, and then Ron, I saw what you had said about, the money spent annually transferring people in and out of Kaiser. You're absolutely right. That would be a very interesting number to see how much is actually spent on those ambulance rides. I don't even know if that's a number that is public that we could find, but I could tell you between UCLA and Kaiser are tons of transfers for higher levels of care. And then now with what's going on, of course, with the surge, the hospitals, now we're keeping these patients. And then coordinating the outpatient care can be a little challenging, finding out, okay, who do we contact at Kaiser, or telling them, hey, you're on your own, just go call Kaiser because we can't set up anything for you here. Kaiser has worked out certain agreements. Like if they don't provide, for example, transplant care, Kaiser uses UCLA for transplants. They have worked out a system there. But still, that's still unnecessary to me to have to work out a system between facilities just because you're HMO and you won't cover anything else outside of your HMO network. And we don't have access to your network to find out who your contracted providers are or vendors are. We have to go back to you, which puts me back on the phone, which puts me back on hold, which puts me back trying to be transferred to find out who has this case, who, this is kind of the ongoing thing I deal with on a daily basis that I'll be dealing with first thing in the morning at 7 a.m. I somewhat kind of love it though. I love being able to help these patients navigate. And I do love my job of helping, being able to explain, like I'm explaining to you guys, I explain on like this at the bedside as well. Like this Jeanna you see right here is the same Jeanna that you get as a patient as well. So hopefully I never see you as a patient, but just know you're going to get the same type of Jeanna. And so I do explain these things to the patients at the bedside because they are so confused. They have no idea what's going on with their insurance. They have no idea why things have to be the certain way, why it's taking so long to get things approved. They have no idea. And that's where I have to come in and explain all of that to them. And sometimes it takes 5 minutes, sometimes it takes 45 minutes to explain all of that. And then, or trying to help them figure out how to cover certain things like, oh, well, that blood thinning medication you really need, I can't really discharge you without it, does have a very high copay. And I walk into that room, I check the copays before the patients, they enter the discharge orders, because I don't want the patient to get out of the hospital not knowing that they have this high copay, because what happens is that you get to the pharmacy and they're like, oh, well, your copay is $147. And you're like, I can't afford that. And so that important medication that you need, the antibiotic, the blood thinner, whatever it is that you need, you're not getting because you couldn't afford the copay. So I go ahead of, I take the step ahead and look at it before you discharge. And when you have that high copay, I come and walk in that room and say, hey, Miss such and such or Mr. such and such, this medication is Eliquis, for example, what's a popular one that doesn't have a generic right now. Your copay is $147. I wanted to make sure you knew that. Is that something that you'll be able to afford because you really need this medication? And if they tell me no, and a lot of seniors are already paying for Medicare. They have to pay for their Medicare Part B and they have to pay for their prescription drug coverage. And even with both of those, it's still their copay, $147. I'm quoting a number for a Medicare patient. And so when that happens, they tell me sometimes, because of where I work now, I don't have that issue as much as my previous experience where I was working with more lower income patients, where I would have to really start scrounging up. And I've even had social workers, I will kind of take some liability, but say I've gone in my pocket and have just purposely just paid someone's copay because I felt so bad for them because they needed that medication. There was no way to get it cheaper. There was no good RX coupons. There was nothing. So, you know, me not even knowing this person or social workers, I know social workers who have gone in their pocket. Like we literally went into our purses and, you know, donated basically to this patient to get them the medication that they need, because it was such a sad story, you know, like, oh my God, this person, you know, can barely afford to live. And we're, you know, so, but that's what's going on across the country and heavily here in California, and even more hyper-focused right here in Los Angeles, where at MLK, I can guarantee you that $147 copay would be an impossible thing to pay for, versus at Cedars-Sinai, where somebody be like, well, it's inconvenient, but I'll put it on my credit card, or yeah, I'll pay for it. That's the medical apartheid you've heard Maureen reference, and so many of us reference. That's the medical apartheid right there. Is the fact that that same blood thinning medication is, you know, will put someone kind of like taking food out of their mouth, literally, for one, and then for another, it's just like, oh, it's inconvenient. Okay, that was my soapbox moment. Any more questions? I know Erica had to hop off. I'm sorry, Erica, thank you so much for joining and helping out. Any more questions? So really quick, I do want to go into, and I'll share my screen again, because like I said, the bill was kind of pulled in last year to work on this funding thing, to have this funding discussion with, you know, the people in the assembly. So I just want to show you a quick tip sheet of ACA 11, which is Assembly Constitutional Amendment 11. Yeah, that's a big one, right? Update. All right, update. So we do have a funding now, right? Okay, and it was brought forth by Assembly Member Kalra, who has been working on it for the better part of 2021, who had been, actually, he mentioned on a call yesterday with LACDP that he literally went to DC, talked to Health and Human Services, found out that we technically didn't need the funding mechanism in this bill to get the waivers we would need to get the Medicare and the government funding for AB 1400. He confirmed that in DC. So we didn't need to have this, but so many people were going to put their foot down if this wasn't there. So here it is, Assembly Constitutional Amendment 11, taxation to fund healthcare coverage and cost control. And so I will, this has been shared. This is, I believe, in our toolkit. I don't know if the link has been added to our toolkit now, but I will drop the link to this in the chat, and then Paul can also drop it here in the Facebook chat. But, you know, so this will be a voter approval, a package of taxes to fund comprehensive universal single payer healthcare and cost control. Man, we're talking about the tax. I know everyone hates taxes. And I'm like, but I want to just ask something. Do you hate taxes, or do you hate the fact that you feel that your taxes are not representing what they're supposed to? Because I don't mind paying taxes for our needs, right? That's what they're there for. They're supposed to be funding our schools, our roads, our, you know, EMS, our public services are supposed to be funded by our taxes. I don't mind paying the taxes for that. I don't. But what we're seeing here is that it's not necessarily happening, or it's not happening the way it should. And that's where I feel most people start bucking against the idea of taxes, because they don't really see the benefit of it, because it's not happening. There's so many kind of red tape, and there's so many kind of backdoor deals and private contractors who get all the favor with the benefits and stuff like that, but they don't deliver. You know, we had a tax for homelessness. Homelessness is still through the roof. You know, all of that is, I believe, the reason why you hate taxes. And for that, I understand, because I'm pissed off too, because, hey, I don't want to be taxed if you're not going to do what you said you're going to do, right? But for this, truthfully, I wouldn't mind, because I know this is going to go where it says it needs to go. So gross tax receipts, right? So annual excise tax of 2.3% of a gross income above how much? Not $2, 2 million for all qualified businesses in the state, 2.3%. I guarantee with a capital G underlined, they are paying more for healthcare costs now. Employer share is way more now than what this is proposing. And then payroll tax. So employer share, employees with 50 or more employees pay 1.25 payroll tax on wages and other compensation for their employees. Once again, employers pay so much in healthcare costs. That's why a lot of small businesses can't afford to provide healthcare for their employees, because it is so god awful expensive through private insurance. It is. And so still, even though we know what's getting ready to come out, we know it's already come out, these op-eds about how we're trying to raise taxes. That's what they're leading with, raise taxes, raise taxes. The reason why I don't have the numbers right now is because it's really hard to put forth these numbers about how much you're actually paying. I looked at the CDC, which was saying per capita, Americans spend about $11,000 per capita on healthcare. And the average income in 2019 for an American was $51,000, 51,000 and some change. So if your average income is 51,000, and then your average healthcare cost is supposed to be 11,000, which this could be a little bit high. Like I said, this is hard to find these numbers, like how much Americans truly pay on healthcare costs. That's a high percentage of your healthcare, of your income just going on healthcare. And I could see if you have a family of, maybe it's you, your husband, a couple of kids, I could see that, because when if you have employer sponsored healthcare and you're selecting your benefits, you got a new job, congratulations, you get a benefits package, even bigger congratulations. But now here you are selecting those healthcare costs, and going back to when you said Kaiser is a choice. No, it's actually going back to what Ron said. This is the reason why it's not. When you go and you select Anthem PPO exclusive, right? You get open access, you can go wherever you want, whatever, right? And it says bi-weekly, $140 something, single plus dependent, 202, single plus two dependents. It grows almost exponentially as you go down and you keep adding people to that plan. You look at Kaiser, well, Kaiser's numbers are a lot cheaper because it's an HMO and you're in the network, you're in the Kaiser family, like a mafia. I always said Kaiser's kind of like a mafia because they do come after their patients. So that's the reason why I say, yes, you do have a choice to choose, but at the same time, most of our choices are driven by finance. What can we afford determines what we choose. So at the same time, we don't have a choice. And so a lot of people choose Kaiser because of affordability, not because it's necessarily the one that they wanted to pick the most. It's just because it was the most affordable for them and their family. So anyway, going back to what this, the employee share or the employer share. So when you have a single public program, when you have CalCare and you're paying these very small, very small percentages of taxes, but you don't have to worry about paying healthcare costs for your employees, I think that's a win. We're going to get pummeled by the story, the narrative of this is going to raise healthcare costs. It's already starting, right? It's already filtering through the news. We don't have, as activists, the thing about being an activist, to me, when you tell me you're an activist, I know you're broke. Right? That's the funny thing about it. The activism, we're broke most of the time. We don't have billions of dollars. Now, if you're a philanthropist, okay, I know you have money, right? Philanthropy is for people who have money. Activism is for us broke, normal people, right? That's how I normally that's my funny way of breaking it down. Not saying that that's exclusive. You can be broke and a philanthropist too. But for the most part, it's us activists who are always weak. When I say collectively broke, I mean, we don't have millions of dollars to put towards like ad campaigns and stuff like that. There are activists out there that are, very, pretty well off. It's just that when it comes to competing with special interest money, we're all broke. So then employee share, going back to this, Employees earning more than 49,000 in wages or compensation per year pay a 1% payroll tax. 1%. You actually are part of the 1% club. Isn't that nice? You're 1%. 1% payroll tax. Right now, I guarantee you, if you are paying your employee share for your healthcare costs, you're paying way more than 1%. Guarantee it. Add it up. Look at your paycheck stub. Look at your last check stub for 2020. Or, oh my God, 2021. Skipped a year. And I guarantee you're probably paying more unless you have your job really did or didn't provide healthcare benefits. And then personal income tax on high earners. Bezos, talking to you. Taxpayer are kind of not, but I'm also talking about just kind of a lot of others too, but Bezos really, but taxable income above 149.5, right, of 509, will pay an additional income tax based on specific marginal tax rates and adjusted for inflation. Now, that does hit a lot of mid-range earners, physicians, high-level nurses, that hits a lot of us too. So it's kind of like, well, what does that mean? And so that may, I understand, make people who are in this range a little nervous because this isn't Bezos. Bezos looks at this and laughs. He would consider this amount to be very poor. But, you know, so this is, I understand where people will be very concerned here. But if, like I said, if I roughly crudely calculated out that I think last year, I felt like I was paying right around 6 or 7% of my income going to healthcare costs. And that was me projecting a couple of urgent care visits, a couple of monthly prescriptions I have to pay a copay for. So that was projecting a little bit. So I still calculate 6 or 7%. So if I am paying, okay, 1% payroll tax, and so I'm still winning. If they wanted to say, oh, an extra 3%, 4%, I'm still getting an extra 2 or 3% back in my pocket, right? So I just want people, the only thing I can ask for is that people have to think. I cannot, like I said, to change this narrative, it's going from us have to be word of mouth. You know, it's going to have to be people like, no, don't believe that. We're not going to be hitting people with 50% taxes as these insurance companies and whoever they hire to write these op-eds will make it seem like. That is not going to happen. Likely, you will see probably either equal change or no change, or maybe even a positive change when it comes to your income if CalCare passes, because you're not having to worry about so much healthcare costs. So just keep that in mind. When you see these op-eds come out, just keep in mind that they are just completely like off the wall, just making there, it's a fear campaign. Just keep in mind, this is a fear campaign. That's all I'm asking. So then ACA 11 ensures that the tax revenue, this is important for people who have been following this. We have talked about the GAN limit, Prop 98, Prop 2. This is important. So ACA 11 ensures that the tax revenues raised do not affect the GAN limit, which we thought might kill this whole thing. The Prop 98 minimum guarantee for schools and community colleges, or reserve calculations under Prop 2 of 2014. I was very happy to see that included into this, because we thought that, okay, well, is the CalCare trust going to be part of the general fund for the state? In that instance, then we would get hit with Prop 2, the GAN limit, and then, you know, all that income that we bring in would be hit to have to be given to schools, and how would we get this funded? So there was a lot of conversation in the beginning and middle of this about these three issues, the GAN limit, Prop 98. And so I'm kind of happy to see that, you know, that they have considered that. And then ACA 11, this is key, very important. ACA 11 would not become operative until legislator enacts a statutory frame for a single payer system, and there is an implementing statute for its tax administration, collection, and enforcement. So once again, this is not operative, okay? This is just here as a safety to say that it is here, okay? We have a plan, if need be, to be implemented. Californians, and I'm sorry, I'm skipping over, but I will drop the links to this so you can read the full page. This is just a one page or two. This is the summary. Californians will have a choice, and the taxes imposed by ACA 11 will result in a net income gain for most low and middle income individuals by eliminating the quote unquote taxes they pay for for-profit insurance. That is what I've been talking about this whole time. This likely will once again be a positive thing for low and middle income, right? That's what I want you to emphasize. That's what I want you to take home. Okay. So as you keep hearing, oh, this universal healthcare is going to raise taxes. Universal healthcare is going to raise taxes. Keep in mind, call them on their BS and tell them that, hey, I'm already paying this so much in healthcare costs. Now, I don't think that this is going to be as much as what I'm already paying. Just keep that in mind. I will drop these links. Thank you guys for listening, but this was a very important thing and gladly will answer questions. As I know it, this just rolled out, so I don't have a whole lot of questions or answers, but I can probably get them asked. Assemblymember Kalra is so accessible and has been so much with us and with Healthcare for All Los Angeles. And, you know, just he's been there for us like lockstep every which way. So I am very happy. And, you know, shout out to Ash for that. Really, really just great overall guy. Just a great guy. Paul, I see your hand up.
Yes, I've noticed that if we were to compare this plan, California single payer plan with Medicare for All and Medicare Advantage, I know we covered this a little bit. I think you said you were going to cover it later on our show. And what comes to mind is that Medicare Advantage is basically, you know, which is an HMO, and you had mentioned that if you're out of network from that HMO, you're going to have to pay for the whole thing. The insurance companies won't cover it. And yet Medicare is paying for everything that goes through Medicare Advantage. And that to me is despicable. And Medicare itself, I mean, when did we start charging deductibles and premiums and you know, having to get Part B and all this? I think it was with the Bush administration, if I remember correctly. But before that, you know, you're a senior. You know, most seniors have a harder time getting work. I mean, it's unrealistic. So, I mean, this bill, and I was wondering if you could elaborate on this, is amazing because you don't have to worry about anything.
Well, and that's true. And I don't want to say, you know, you don't have to worry about anything, but when it comes to cost, when it comes to finance being your driver, I don't want people to feel, once again, that your healthcare is driven by your finances. The type of healthcare you get is driven by your finances. You can't afford it. I mean, it's kind of like, you know, in a sense, you know, I was talking to Erica and we're talking about Squid Games. It's kind of like, yeah, like you have a medical debt. Now we're going to put you through the ringer on how to pay that off. We're going to put you through the ringer of, you know, what you can do. We want to see how many hoops you will jump through. Just like those people in Squid Games competing for those games. And if they did something wrong, you were killed. Same scenario. I'm pretty sure they wrote that based off America. Anyway, you know, same scenario. Like with the healthcare, we're making you jump through hoops to get the care that you need. You may live, you may get it to, you know, and that's it, man. That's what's going on. When it comes to Medicare Advantage, I'll have to actually look and see when they started actually when that fee, like having to pay the $140 something, which is which was the 2021 numbers for Medicare Part B, which was the like hospital and stuff coverage. But I know that, I don't know when I'll have to look that up, but Part C Medicare, which started coming out in the 70s or 80s, or the 80s, somewhere in there, it was proposed and it started really becoming big in the 90s. Yes, the way that it works is Medicare pays into whatever the plan's pot is or whatever group is managing that you know, patients, they pay into a pot every month, right? And it's up to that plan to manage that money to where they gain profit to cover their operational costs, basically, right? So that is how Part C is. Medicare does pay for Part C, and then it's up to the plan and the group, the medical group, to manage your benefits and to basically see a profit. It was supposed to drive them to keep you healthy, right? That was supposed to be the thought process was, well, the healthier you keep the patients, the lower utilization that they have, the more money you get to keep, right? That was supposed to drive that. Instead, what happened is that, well, patients are still unhealthy because that's only one faction of it. Just driving, keeping utilization low, it doesn't mean necessarily you're keeping a patient healthy. And there's so many more factors that go into keeping a patient healthy other than just trying to keep their healthcare utilization low. There's the whole patient is a very different thing. And how much they just go to the doctor doesn't determine how healthy they are. But once again, that's a whole nother topic. But so that's how Part C works. So they were incentive driven. So to save money, to have profit, you were supposed to keep the patients healthy. Well, they also have that. There is a big push to keep the patients healthy. They do have programs, diabetes programs, certain programs, which are good. Kaiser has tons of programs to keep patients, or to try and keep patients healthy. I don't oppose that. I want to see that driven into CalCare too, all these preventative medicine programs, because healthy patients are happy patients and productive people. But when you are negotiating contracts and you're shopping around to find out what place has the lowest rates, that's what you're determining. Who you contract with is who has the lowest rates, and that's like the first thing you care about. Maybe the third thing you care about is actually the care outcomes. The second thing you care about is, are they like credentialed? Do they have all their licensing and bonding so that you make sure that you get paid from Medicare if patients go there? Then the third thing, you're like, okay, what is your outcomes? So it's like, okay, patient outcomes is like the third on the list that they're considering when they're shopping for their network. And that is a problem. And, and insurance companies will say that's not true. We don't do that. Patient outcomes are always number one, but I can guarantee you they're about third on the list. Because yes, Medicare does want to see outcomes. You can't just be a shitty plan. You have to present outcomes. And if you are not meeting certain outcomes for an extended period of time, you can lose your Medicare funding. But it's really hard to, trust me. And everyone skims the line. Everyone just hits that line. Or tries to stay just above it, excelling above it. No, but in the managed care world, it can be really tight. Sorry, was that a 10? Did I answer your question, Endora? Did I go way too left field?
Yes.
Okay. All right. Well, with 10 minutes left, did anybody else have any other questions? Or Paul, do you see anything in Facebook?
Not right now.
All right. Well, I have a call at 8 to discuss AB 1416, Jeffrey. So, if no one else has questions, I will give you back about 10 minutes. And stay tuned. We'll be doing, because we're going to go through health committee next weekend, next Sunday, same time. We're going to do another office hours to provide you with more updates of how we went with the health committee. In the meantime, please feel free to reach out to your assembly member and ask for their support. Even if they're not on the health committee, continue to reach out to them and ask them to support. If they tell you that they're not supporting and give you a reason, feel free to message us at the Healthcare for All Los Angeles page on Facebook. We'll see it. And so that we can maybe even give you talking points to counteract this. Some people are not going to support it because, well, they just have too much special interest on reasons and not to support it. And that's okay. I don't need every single one support. I just need enough to pass. And so if you can counter that though, see if they'll tell you why they're not supporting it. If it's a funding thing, please feel free to tell them to refer to Assembly Constitutional Amendment 11 that Assembly Member Kalra has introduced. So if it's a funding thing, and like I said, if you have a question, feel free to come back. You can message us at the Healthcare for All Los Angeles page. We'll be back next Sunday to give more updates. I've enjoyed doing this with all of you guys. Thank you so much for your questions. And once again, you guys have a happy Sunday. I would not be a good nurse certified in public health if I did not tell you to wear your mask, wash your hands, stay distant, and stay home as much as possible. I really do want to make sure that as many of us survive this thing, even though it's day 662. I calculated that. All right. You guys have a good one. Take care, everybody. Bye.
Bye.
Thank you, Gina.
No problem. Thank you.